has suggested that direct-to-consumer genetic test, we had a hearing on that just last week, those should be classified as medical devices for the purpose of oversight. Do either of you believe that the FDA should consider electronic medical records as medical devices for the purposes of regulating these records?
Congressman, our concern and the concern of the policy committee that you cited was to take maximum advantage of health information technology and electronic health records to improve the safety of care. And what actually the committee focused on, in addition to the FDA, was other alternatives for collecting information about the implementation of electronic health records to make sure that those implementations are as safe as they could possibly be. So we also discussed using patient safety organizations and using our new certification process to collect post-surveillance, post-certification surveillance information. So I think that the mandate to us, the recommendation to us, not a mandate, was to develop and look at all the ways we could collect information to make sure that our work was doing everything it possibly could to enhance patient safety. Now, whether or not the Food and Drug Administration takes any action beyond what it already has, I think is premature to speculate about. They have no plans right now that I'm aware of to do anything further than what they've already done. So we're right now at the department looking at these information collection opportunities that we already have and have created and not looking at anything else beyond that.
Mr. Trinkle, do you have any further comments on that? Do you?
No, I agree with what Dr. Blumenthal said.
Well, I thank you. I hope that I understood correctly your response, Dr. Blumenthal, that you really don't think that the FDA should treat electronic medical records as a medical device.
Well, there are legal issues which I'm not qualified to speculate about as to what a device is or isn't. From the standpoint of policy, I would say that there is no plan right now for the FDA to do anything of that sort.
Thanks. I've got about 2 minutes left. Technology companies have told me, and we have a very good one in my district, 11th of Georgia, in Carrollton, Georgia. I won't mention the name of the company, but they're very good, and they've been out there doing this for a while. That is providing electronic medical record hardware and software to specialty-specific groups, general surgery, OBGYN, et cetera. And they have told me how critically important it will be to have 12 to 18 months of lead time in order to align their products with the Stage 2 criteria. Understanding how critically important quality products are to the viability of our future nationwide network, can you give these companies, like the one in my district, some public reassurance today that the development of Stage 2 criteria will allow these companies 12 to 18-month window in order to bring their products into compliance?
We are going to do everything we can to give companies as much warning as they can about what the criteria will be. And we want to have time to learn from Stage 1 about what the experience has been of providers and vendors and others, patients, with the new rules and implementation efforts. So we want to wait a while before we get that experience. Then we also want to get the rules done as early as possible.
Sure. Well, I think I interrupt you, but I definitely want to ask Mr. Tringle a question before my time runs out. I've got 10 seconds. You said to one of my colleagues that the issue of the final rule in the hospitals that have multiple campuses, that they would just be eligible for one meaningful user incentive payment for Medicare and Medicaid. How about physician groups, let's say a family practice group of 5 individual physicians, they're affiliated in some way. How would you deal with them? Would that group only be eligible for one payment, $44,000 or $77,000, whatever it is, or multiple payments for each individual doctor?
Yeah, I just want to add one thing to the previous question on the meaningful use stage 2. We've, in addition to what David mentioned, we've also signaled in the preamble for this particular rule that we were going to move the menu items to be core objectives for stage 2, and also signaled our intent to add administrative transactions in stage 2, as well as increasing the percentage measurement for computerized physician order entry. So we have given some signals. But to answer your second question, we have, for this particular rule, we have payments are made to individual eligible professional. So they're not made by group, they're made by professionals. And we made that decision very much after listening to some of the comments, reading some of the comments that came in, and listening to some of the concerns that people had on both sides. We felt that the way the legislation was written and the ability to track the dollars spent and the performance to meet the criteria, we have determined that we would go with the individual eligible professionals. So if there's 5 members of a group practice, each one of them would have to show meaningful use to meet the requirements to get an incentive.
But they would each be eligible if they did for the bonus payment.
That's correct.
Mr. Chairman, thank you. I thought that was very important. I'm glad